Good morning and good afternoon, evening to our colleagues across the world. Thank you for having me. My name is Dr. Vikram Mukherjee. I'm a physician here at Bellevue Hospital in New York City, and I work as an intensive care physician here, where I direct our medical ICU. For the next 15 minutes or so, we'll talk about respiratory failure and COVID-19, the predominant reason why patients with SARS-CoV-2 infection fall ill, get hospitalized, and present to the ICU, and sometimes even, unfortunately, pass away. I have no relevant financial disclosures. And we'll start with the basic slide here, where we go over the time course and the different categories of illness that SARS-CoV-2 infection presents with. As you can see here, asymptomatic or pre-symptomatic, mild illness, moderate illness, severe illness, and critical illness. For the purpose of today's talk, we will be focusing on these two categories here. As you can see here, there is a nice phasic response here between viral replication in the first few phases of the illness, and this will pertain on our therapeutics, but inflammation plays a huge role in the severe and critical illness parts of this disease process. Similarly, management considerations, we'll be talking about hospitalization, oxygen therapy, ventilator techniques, and of course, specific countermeasures which can help in patients who are presenting with severe or critical illness from COVID-19. We'll briefly cover pathophysiology. So as you can see on the CT scan section up on the slide, on the picture above, COVID-19 presents as classical acute respiratory distress syndrome, and the management of this follows very in line with management of ARDS. As you can see here, there are dense consolidated here, parts of the lung here. There is ground glass opacities here and pretty healthy lungs up here, and the famous Dr. Gattinoni's baby lungs here. However, there might be more to the puzzle, and this is some vascular pathology that has been hypothesized, and the inflammation, the hypercoagulability might also predispose patients to not just parenchymal disease, but also vascular involvement with worsening of VQ matching as part of the inflammatory process. So basically, now that we understand briefly that patients with COVID ARDS, COVID respiratory failure present classically as acute respiratory distress syndrome, now we'll talk about these four broad categories, principles of ARDS management as a whole. I would like to emphasize that we should try our best to avoid pandemic exceptionalism. We've dealt with a slippery slope over the last 18-20 months here in the US, where we've thought about happy hypoxia, we've thought about hypercoagulability as a predisposing factor, and so on, and have tried to treat patients differently than we would treat with the COVID ARDS, than a classic ARDS. And I would suggest that we hold off on that and treat our patients with the time-tested techniques of classic lung protection, which we'll come to. Of course, this is an extremely infectious virus, as you've probably heard from many of my colleagues in this talk already, and especially in the ICU, where you have so many aerosol generating processes happening all the way from intubation to extubation to chest compressions to bronchodilator therapy, nebulizers, non-invasive. You have to have significant airtight infection control practices implemented when you're managing a patient with respiratory failure in the ICU. Of course, not only is that better for patient care, but also it will protect your staff. And you really need to have a healthy, functional workforce to be able to provide significant, critical care capacity to the patients in need. So infection control practices, be it filters, be it negative pressure rooms, be it air doors being closed, have to be integral to your management of a COVID-19 patient in the ICU. And in the long-term care, as many of you who've worked in the COVID world already know better than me, is that many of your survivors will be left with fibrotic lung disease and will need long-term weaning. And we'll come to that because that's the post-ICU trajectory of care, which we should also pay particular attention to, and also prepare the family for as the time goes by. So acute respiratory distress management. Let's first talk about a patient coming into your ICU and hasn't been intubated yet. Significant data showing that self-proning before intubation has benefit. And so you should be encouraging your patients to do awake self-proning as much as they can. Try to keep your SATs more than 90% as much as possible, and this will help reduce progression to critical disease, will help stave off an intubation, will help progression from moderate ARDS to severe ARDS in certain patients. Now, also, data is pretty clear is that there is a low incidence, less than 5% of bacterial superinfection on presentation of patients. So yes, of course, in the patient in extremis, consider a trial of antibiotics. But if within 48 hours you haven't grown anything yet on your lab, you might want to de-escalate and just treat with without antibiotics for the first phase. Unfortunately, many of your patients will proceed to requiring ventilatory support. We should have a very cautious approach to non-invasive ventilation. As many of you know, having a BiPAP on a patient doesn't allow you to manage with lung protective ventilation, and you're not able to control your tidal volumes. The transalveolar pressures are immense, and this might worsen your vent-induced lung injury and predispose to further lung injury, further multi-organ failure. So unless the patient is do not intubate, do not resuscitate, goals of care, have a very cautious approach to non-invasive ventilation, and there might be a case to make that you go from high flow nasal cannula to invasive mechanical ventilation, skipping this middle step, which might cause further vent-induced lung injury. Once the patient is intubated, again, the classic teachings of acute respiratory distress management applies here. You want to make sure the lungs are protected. So dial down your tidal volumes as best as you can to 6 cc's per kilogram of ideal body weight. Allow for permissive hypercapnia, permissive hypoxia, and protect the baby lungs as best as you can. Individualized PEEP strategy is key here. What we found here at the bedside and we published is that a very aggressive PEEP strategy worsens your dead space and makes your CO2 clearance worse. So following the classical ARDS high PEEP to FiO2 ladder may be a bit detrimental, not just from hemodynamics, but also from worsening your dead space fraction, worsening your gas exchange. This happens more so because many of your patients, because of the insensible losses and the high fevers, have very low intravascular volume. And as you increase your PEEP, your west zone ones of the lung worsen, and your gas exchange worsens as well. Supportive therapy, try for inhaled NO that improves your P2F ratios, might help your right ventricle in being able to, by improving your pulmonary vasoconstriction. Have a low threshold to start a trial of neuromuscular blockade. Many of your patients will have significant ventilator dysynchrony, and neuromuscular blockade will be protective in that setting. However, know well that this will predispose the patient to long-term critical care weakness, diaphragmatic weakness, and so a initiation, but a hard stop at 36 to 48 hours, and reevaluating the patient at that time frame to see the need for further neuromuscular blockade is probably a prudent thing to do. Prone positioning should be absolutely key to your management as long as the patient can tolerate that. You should be pronating the patient for at least 16 to 18 hours a day. And that, as you know, the data is very clear on this, has significant improvements in mortality, in gas exchange, in VQ matching, in shape matching, and so on. Similarly, similar to the PEEP strategy, have a cautious approach to recruitment maneuvers. As you know, many of these patients are hugely susceptible to barotrauma and, of course, hemodynamic collapse. So if you do a recruitment maneuver, do it extremely carefully to find your optimal PEEP. There might be a case to make is to avoid recruitment maneuvers altogether and have a very individualized low PEEP strategy to avoid ventilator-induced lung injury. Moving on, we'll briefly talk about medical countermeasures. And the first thing I want to emphasize is hopefully something that's common knowledge already is that vaccines, an ounce of prevention is always, as you know, better than a pound of cure. And vaccines have shown to be terribly effective in preventing ICU admissions, hospitalizations from COVID respiratory failure. So advocate for that. Even in the Delta strains and non-native strains, vaccines have so far shown to have immense benefit in being able to prevent severe disease, critical disease. So whether it's a booster or double vaccinations or what have you, make sure your patients are vaccinated to prevent an ICU admission or a hospitalization. The other 5 therapeutic measures that we'll talk about are as follows: steroids, remdesivir and antivirals, tocilizumab, baricitinib, and a brief approach on anticoagulation. The strongest benefit in respiratory failure, the data is behind steroids, and this comes out of the beautifully done recovery trial out of NHS, which shows, as you can see in these Kaplan-Meier curves, beautiful improvement in mortality in patients who are critically ill and are and have invasive mechanical ventilation on. And as you can see here in these Kaplan-Meier curves, the benefit starts at 7 days and then goes on to at least 28 days. Significant risk reduction in mortality in patients who are intubated when you use dexamethasone. So has to be key to your practice. I think the jury's out here. I think there's no debate here that steroids are a standard of care for patients with COVID ARDS, and probably based on the DEXA ARDS trials on all patients coming into your ICU with acute respiratory distress syndrome. As you can see in the other 3 Kaplan-Meier curves, the benefit doesn't quite extrapolate to non-intubated patients and actually might have a small significant, signal of harm in patients who are not on oxygen. This might have something to do with viral replication, but for the purpose of our talk, intubated patients, patients on IMV have a significant benefit with steroids, and this is something that you should be using as standard of care. We'll briefly talk about other countermeasures. Unfortunately, the evidence behind any of these countermeasures in treating a patient with severe ARDS isn't as strong as what we saw in steroids. However, this is something that you might want to consider: remdesivir to improve your WHO ordinal scales, tocilizumab to use in the inflammatory phase of ARDS, baricitinib in combination for remdesivir to improve time to recovery. And anticoagulation, have a nimble approach to anticoagulation. Just recognize that patients with COVID ARDS or COVID infection are hypercoagulable and might need a very nuanced approach to systemic anticoagulation, especially in the ICU. I'm going to talk about de-escalation next. Of course, aggressive weaning of the ventilator is key if it's done in a safe manner. We should recognize that COVID patients with SARS-CoV-2 infection intubated have a huge risk of diaphragmatic dysfunction, of neuromuscular weakness, especially because they usually get intubated for many, many days. As you heard, they should be on steroids. Many of them are on neuromuscular blockers, and all of these make the diaphragms very weak and the chance of extubation weak. Therefore, many patients will need long-term weaning, especially if they enter the fibrotic phase of acute respiratory distress syndrome. This leads to a tracheostomy, often a PEG tube placement, physical therapy. This is something that we should be preparing our families for, that of the ICU survivors, of patients who survive an invasive mechanical ventilation, many of them will need long-term weaning in a long-term acute care facility for rehabilitation and vent support. Refractory ARDS, of course, we haven't spoken about this, and I kept it as an end, is the role of veno-venous ECMO. We know well that referral to an ECMO center based on the CSER trial is the right thing to do, but we should always keep our ECMO support on patients who are good candidates who have failed all the other conventional therapies of ARDS management. The EOLIA trial, while there's a big crossover rate, showed that in patients with acute respiratory distress syndrome, severe ARDS, ECMO should be used as a salvage therapy. So refer your patients to an ECMO center, of course, but if you work in an ECMO center, I'm sure you're doing this already, but have ECMO as a salvage therapy on patients who are good candidates, young, single organ dysfunction, who have failed proning, failed neuromuscular blockade, failed paralytics, and neuromuscular blockade, and then think about ECMO. Most of our patients who've been on veno-venous ECMO have had a prolonged run with all the complications that come with it. And anecdotally, this could serve as a bridge to transplant. Of course, there's a huge discussion there to be had, but VV ECMO could possibly serve in the right candidate as a bridge to lung transplant in patients with fibrotic non-salvageable lungs. I'm going to stop there, and hopefully this was useful, and open up the floor to any questions that you may have. Thank you for your time.